me, ladies and gentlemen. We now have our presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the Q&A pod located to the left of your webinar platform. You may also download a copy of today's presentation using the Resources pod located below the Q&A pod. It is now my pleasure to introduce today's first presenter, AHA moderator, Gloria Kupferman. Please go ahead.
Hi, everybody. Thank you very much for joining us. My name is Gloria Kupferman, and I'm the Chief Data Strategy Officer at the American Hospital Association. I'll be your moderator for this webinar. This is a particular interest for me as the Chief Data Strategy Officer because, of course, the timeliness of the topic and how important it is, but because this presentation really focuses on using data to understand the causes and risk factors and apply that data in making decisions in how to address the problem proactively. So I really appreciate the opportunity to participate in this webinar with you. AHA's Hospital Against Violence initiative focuses on community violence, violence in the workplace, and particularly violence against the healthcare workforce. Earlier this year, AHA launched the Public Health Approach to Gun Violence Prevention program, and today is the second webinar in that series. This series will cover topics ranging from gun violence research, like today's webinar, the burden of firearm-related injuries, hospital-based violence intervention programs, and community-based solutions and to violence prevention. So we want this experience to be interactive. The audience is live, but your lines are muted. So please use the chat box and submit your questions that way. I will be moderating the Q&A section at the end of the presentation, and I'll do my best to get all of your questions answered in the order they're submitted. Today's webinar is the role of public health research in gun violence protection, and it will provide an overview about the current state of research on firearm injury, where the field is heading in addressing this issue, and what is still needed. This public health focus will provide our hospitals and health systems with strategies for prevention and care to victims of firearm violence and make the communities we serve healthier and safer. We're very happy to welcome Dr. Megan Rainey. Dr. Rainey is the Chief Research Officer at Affirm Research, which stands for the American Foundation for Firearm Injury Reduction in Medicine, and they're the country's leading nonprofit organization committed to ending the gun violence epidemic through a public health approach. Dr. Rainey is also a practicing emergency physician, a founding director of the Brown Emergency Digital Health Innovation Program, and an associate professor in the Department of Emergency Medicine at Brown University's Alpert Medical School. Dr. Rainey's career focuses on developing, testing, and disseminating digital health interventions to prevent violence and related behavioral health issues. She is currently principal investigator or co-investigator on 9 federally funded grants and holds numerous national positions. We also encourage you to check out Dr. Rainey's TED Talk, which is entitled How the Public Health Approach Can Solve Gun Violence. So we're delighted to welcome Dr. Rainey. So I will cue up her slide for her and turn it over to Dr. Rainey for the presentation.
Thank you, Gloria. It is an honor to be here, and I'm excited to get to talk to all of you today. As Gloria and Stephanie gave as an overview, I'm going to try to keep this talk to about 35 minutes or so that we have time for Q&A at the end. So I'm going to talk today a little about the role of public health research in gun violence prevention with the very clear caveat that there is no way I'm going to be able to make it through all the details in the course of this study. So in the course of this talk. So I'm really going to provide a high-level overview of why research is important, some of the ways in which it is already making a difference, and where those of us that are active in firearm injury prevention research see the field going next. As disclosures, I do have NIH research support, including for firearm-related injury research. I chair our Rhode Island Task Force on gun violence prevention. I'm the Chief Research Officer for our firm research, and I'm also co-founder for Get Us PPE, but I have no financial conflicts. I also want to acknowledge Dr. Emmy Betts and Dr. Garen Wintemute, with whom I have designed and presented parts of this talk before. I think it's really important for those of us in medicine and particularly in research to acknowledge the fact that we always work with a team, and these two folks are a big part of mine. So I encourage you to check out their research. So I start with a story about why I care about gun violence. I'm an emergency physician, and like most ER docs, taking care of gun violence is really part of the bread and butter of my profession. During residency, I saw more victims of community violence than I can count. But in my very first years as an attending, right in around the change of residency, so early July, I was working a Saturday night in the trauma rooms at my hospital. And we had a call come in from EMS saying that they were on their way with a GSW code blue, so gunshot wound code blue, which on a warm Saturday night was not an unusual occurrence at that time in Providence. We prepped the room the way that we've done throughout my residency, throughout my training, had all the brand new students and interns and second-year residents who thought that they were going to get to see their first trauma code, their first thoracotomy. There was a buzz in the air. And then EMS rolled in. And as they brought the patient into the room, we looked, and the room went quiet because this patient was not what we had expected. First, it was a young white man. It was not what we thought was coming in. And second, this patient was shot in the head. And as we got the story from EMS, it turned out that he had shot himself. The air went out of the room. We kept this very young man alive for a little bit. It turned out that he had shot himself with his father's gun. Father was a member of our local law enforcement and first responder community, and so got to the hospital really quickly and said goodbye to his son. And the moment stuck with me and really shifted the way that I approached gun violence as a public health problem and drove my approach to research for a few reasons. The first is that incident highlighted to me the degree to which we accepted at that time, going back 15 years or so now, the degree to which we accepted gun violence as inevitable. This case took our breath away because it was so unusual to us, but we just accepted that things were going to come in and that we weren't going to be able to prevent them. Second, it highlighted the degree to which that was tied up with structural racism. The fact that this kid was not a minority youth was part of what changed the room, and that just struck me as unacceptable as an emergency physician. And the third thing was, here I am 15 years out, and that patient is one of only 2 patients I've ever taken care of who shot themselves with a gun, and both of those patients died. Now, as an ER doc, I take care of, a half dozen patients with suicidal ideation or suicide attempts on every one of my shifts. And the fact that I had never seen someone try to hurt themselves with a gun before stuck with me and made me start wondering why, and made me start looking into the degree to which access to a firearm really drives suicide. And I'll talk a little bit about that. I think it's important for us to start with those stories because the human stories are so often what motivate us and keep us committed to doing this research and to create a change. And there are 3 other main drivers for me as I do this. This slide, on the left, you see a picture of Jay Dickey, who is responsible for the now infamous Dickey Amendment, which essentially, although not by the language of the law, banned the CDC from doing gun violence prevention research since 1996. So he helped motivate my work because it was thanks to him that there was very little funding for gun violence prevention research, and it was that lack of funding that led to my lack of knowledge in that case that I just shared. The second picture, of course, is a picture of the victims of Sandy Hook, which I think was a turning point for our country in talking about gun violence as a public health problem. Dr. Betts, Dr. Wintemute, and I had been talking about it since long before Sandy Hook, but that really served as a transition point where our medical societies and our communities started looking in more detail into how we could address this as a public health problem the same way that we do for other injuries. And the picture on the right is a picture of Dr. Tamara O'Neill, a fellow emergency physician who was shot and killed by her ex-fiancé as she left her emergency department shift in Mercy Hospital in Chicago in the fall of 2018. And I put her picture up because I want to highlight that this is a problem that touches many of us personally, and also that we are not immune. And Tamara's story helps motivate me and many others in pursuing prevention techniques that work for all of us and that help to protect us and our communities from the effects of gun violence. The underlying thesis of this presentation, of course, and of AHA's work is that physicians can and should help reduce firearm injuries and death, but that we can do it using evidence-based methods that are acceptable to all patients and clinicians. And in order to have an evidence base, you, of course, have to have research. Now, I talk about gun violence or firearm injury as an epidemic. And when I do this, people challenge me. They go, oh, it's not really an epidemic, right? It's not like COVID-19. Well, the CDC's official definition of an epidemic is the occurrence of more cases of disease than expected in a given area or among a specific group of people over a particular period of time. And we know that firearm injury concentrates among certain groups of people and among certain geographic areas. Although it is certainly distributed across the United States, we find that there are clusters, and we know that the rate is rising across the United States. So it very much fits the definition of an epidemic, even if it is not an infectious disease. Now, I know that we all experience the fear of mass shootings. I am a mother of two. Sandy Hook affected me immensely, as has every other school shooting. But the reality is, although these are events that should never happen, although they are horrific, they really represent less than 1% of overall firearm injuries and deaths in the United States. I think they are the canary in the coal mine. If we can reduce other types of firearm injury and death, we will likely have a positive knock-on effect on the incidence of mass shootings because it's all interrelated. But I think that it's inappropriate of us to focus exclusively on mass shootings. And as I'll talk about, most of my and others' research on firearm injury prevention actually talks about the much more common types of injury. Across the United States, more than 100 people are killed each day. And there are more than 200 who are injured each day. Of those, 2/3 of the gun-related deaths are suicide. This is critical, again, because we focus so much on those mass shootings, on El Paso, on Thousand Oaks, on Sandy Hook, and ignore the daily trauma that is happening across our country. The rates of firearm death are increasing. This map, if you go from left to right, takes from 1999 through 2017, and then you have the rate per 100,000, so corrected for population, along the y-axis. You see that quote-unquote accidental or unintentional gun deaths are essentially flat. Those are things like, a kid finding a gun in their mother's pocketbook and shooting themselves or their mom, or kids unintentionally shooting each other when they think that a gun is unloaded. Those, again, are totally preventable, which is why I don't like calling them accidents, but they are a very small percentage and are essentially steady. You see that homicide and legal intent, after we got through the late 90s, stayed essentially steady and then has risen dramatically in the middle part of this last decade. I put the two together because they are quite difficult to separate with the current data that we have, although there is growing data around the rate and prevalence of police-related shootings, and that's an important growing part of research. What you'll see here is that the largest increase in firearm injury deaths is suicide. And as I'll talk about, this is a huge area of research and a part where we can help make a difference. But when I talk about the importance of public health research, the first part of it is knowing this epidemiology, knowing the numbers. Because if we don't know what the patterns are of gun deaths, we can't help or we can't hope to address and reduce them. Firearm mortality is something that affects every state in the United States. There is a common misperception that this is a problem of urban areas, but actually the states with the highest age-adjusted death rates are states such as Louisiana, Missouri, Montana, Mississippi, and Alaska. This is a problem of rural states just as much as, or even more than, urban states. We do, of course, find that there are clusters of death in urban areas, but studies have shown that the overall age-adjusted death rates are actually quite similar between most urban areas and rural areas, and that's largely due to the higher rate of firearm suicide in rural areas. And importantly, when we do this research, we find that almost all of us know someone affected by gun violence. Certainly young minority men, and I'll talk about this, are disproportionately affected, but so are the military, so are healthcare providers, so are the police, and we need to acknowledge the degree to which this permeates our society in a silent way. So looking more closely at the epidemiology of gun violence, let's look at who dies. So going along the x-axis here are age groups in 5-year increments from 0 up through 85 plus. On the y-axis are absolute numbers, so not corrected for population, going from 0 to 4,000. This is the pattern of deaths from firearms among males and among females. So in 2017, we found that 86% of firearm deaths were males. I will say this is similar to patterns of injury and death from other types of injuries. Guys are just more likely to get injured, and we can talk about that separately. You'll see there's a big spike in the young adult years and then a plateau that goes right up through the early, up through middle age and early geriatric years. For women, we see a little spike after around age 15, but then the rate of firearm death stays pretty flat, and the majority of these deaths are intimate partner homicides. 76 women are shot and killed per month by a partner, including, of course, Dr. Tamara O'Neill, whose story I mentioned at the beginning. Diving more deeply into men, I'm not going to talk a lot more about the epidemiology of death among women, but diving more deeply into deaths among men, again, I have age groups along the y-axis and absolute numbers of deaths along the y-axis. This is the pattern of death among non-Hispanic white men, non-Hispanic black men, and the black there is Hispanic men. And this graph to me is critically important for those of us interested in both doing research and prevention for two reasons. The first is that you see that young minority men are disproportionately affected by gun violence. A young minority male, particularly a young black male, has 20 times the risk of dying from firearm injury compared to a young white man. And that is not because race is a risk factor, it is because of structural racism as a risk factor. Nonetheless, 62% of deaths are non-Hispanic whites. And I emphasize this because I think it is very easy for people to say, oh, well, this is a problem of the other. This does not affect me. Well, 2/3 of gun deaths in our country are white men, and those deaths go, again, through middle age and up into the elderly age brackets and are something that require our attention. Those are more often suicides than homicides, which is what we see in the young adult years. This, for some reason, I apologize, the PowerPoint, there are two pictures here that didn't translate well when we uploaded it to the webinar, but this one emphasizes that there are approximately 330 million guns in private hands in the United States, but there were only, quote unquote, about 40,000 gun deaths in 2017. This is important because as we talk about research, it's critical for us to be honest about risk. And the reality is that although 40,000 gun deaths is far too many, and although the public health approach, as I'll talk about, can help reduce that, most guns are not used to harm someone or to harm oneself. And so there is a really important distinction for us to make here to look at how do we decrease risk from gun ownership for people who are higher risk for injury or death, while recognizing that the vast majority of guns are perfectly safe. As I talk about the number of guns that are in private hands, I will acknowledge we don't have great national data, and this is the numbers are changing. So this slide comes from the National Shooting Sports Foundation, which is basically the trade association for gun shops. They did a non-scientific survey of gun shop owners during COVID-19 and reported a huge spike in firearm purchases during the last 3 months of 2020 during kind of the COVID-19 pandemic. And they estimated that approximately 40% of those purchasers were first-time gun buyers. And I'll talk about why that's important going forward, because as some studies have shown, first-time gun buyers may be at higher risk for a number of reasons. As we talk about firearm ownership, additionally, I want to highlight the degree to which, again, we cannot demonize gun ownership if we want to fix this problem. This is a picture of me with Colonel Jim Manny, former Secret Service agent, former state trooper, now the colonel of the state police in Rhode Island. He and I co-chair our gun violence working group in this state. And we have, by working together, helped to enable some really positive changes in our state that would not be possible if we were coming at this from a perspective of public health versus gun owners. Instead, this is about public health including gun ownership and elevating leaders within the firearm owning community as part of the solution. This picture is of Dr. Chris Barsati, who is a fellow emergency physician. He is a rifle firearm safety instructor, and he's my co-founder of a firm. And he talks about firearm ownership as being a heritage and a privilege, as well as being a right, and talks about the importance of safety and risk assessments. And by working with folks like Chris and Jim, as we create a public health approach and as we do research, we make sure that the interventions and the prevention strategies that we come up with make sense to the communities that are most at risk. So what is the public health approach to firearm injury? Well, briefly, it is a 4-step approach that most of you on this call probably already know, right? Step 1 is gathering data, looking at epidemiology, the types of things that I just talked about, those patterns of injury and death, racial and ethnic distributions, age distributions. Once you know who is getting injured and killed, then you work to identify risk and protective factors, right? This is the basic part of research. We look at, of those who are injured or killed, why? Are there things that distinguish them that we could intervene on? Then we develop and evaluate interventions. This step, of course, is critical and is the crux of more advanced research. And then once we have things that work, we implement. And one thing that I've seen in the gun violence prevention field is that because we had so little research for so long, we really were developing and implementing interventions without data. So when people say, oh, well, you know, you've had these violence interruption programs in Chicago or St. Louis and gun violence rates are still going up, well, we never had the data to evaluate the efficacy or to evaluate the most powerful components of those programs, nor to refine them before we implemented them. We acted without having the full benefit of research. Now, when you use this 4-step approach, of course, it works. I'm going to give 3 examples. The first is car crashes. So car crashes reached an all-time peak in the late 60s, early 70s, and since then have decreased. The rate of car crash deaths has decreased by 70%. That's despite there being more cars on the road, despite there being more millions of miles traveled by Americans, of course, leaving out COVID-19, where we know that car crash deaths have dropped even further because nobody's driving. But the reason for this drop is because we applied the public health approach, and we didn't take cars off the road. We used this 4-step public health approach, this research-driven approach to preventing car crash injuries and deaths in order to implement interventions that worked. Things like identifying that drunk driving was a risk factor and then putting in place policies, but also education. How many of us have said to a friend, hey, you've had 1 drink too many, let me take your keys, let me drive you home, right? We created car seats and teach parents how to use them and do anticipatory guidance during pediatric visits. We changed the design of cars and roads to make car crashes less likely to happen and to make them less dangerous when they do happen. So that 4-step public health approach worked for car crash deaths. Along the bottom in red, you see HIV/AIDS. Of course, HIV wasn't known prior to the early 80s. We had a tremendous spike in death rates, and death rates from HIV have since dropped by more than 90% through research, through that public health approach. We know because of research that banning sex does not work. Abstinence-only programs don't reduce transmission. Instead, it's educating about safe sex, providing safe injection facilities, harm reduction, as well as, of course, the science of discovering the virus, discovering antiretrovirals, and making them available. Now compare that to firearms, which are the orange line. We had a spike in the mid 80s and 90s, largely due to the crack epidemic. The rate decreased as we kind of got through those quote-unquote drug wars. But as I've mentioned before, we are seeing a dramatic rise in firearm injuries and deaths year on year over the past 4 or 5 years. And I would argue that it is because we have not systematically applied this public health approach. We do have ideas for what we need to do in order to do research. This is a smattering of the papers out there that outline the research agendas that are needed in order to provide that public health approach to firearm injury prevention. There is a piece that Laura was part of, Castellanos from the AHA actually, where we worked with the National Academy of Medicine. There was an early Institute of Medicine report. There is a consensus-driven research agenda from the FACTS Consortium, which I'm part of, for specifically research on firearm injury among children and teens. There's recommendations from the American College of Surgeons, from the American College of Emergency Physicians. So we have these agendas. We know what steps are needed in order to develop the same sorts of changes in firearm injury and death that we've been able to effectuate for things like HIV/AIDS and for things like car crashes. Last winter, the American College of Surgeons actually got together and codified as a group. We've brought together 41 different medical organizations and codified what are the top public health interventions that currently have some evidence behind them and where do we need to go next. And so I highly recommend for folks that are interested that they read this paper after this webinar. But unfortunately, we have been hamstrung by that lack of funding over the last 23 years. As I mentioned early on, Jay Dickey passed that Dickey Amendment, which, although it didn't actually ban CDC funding, at that time, all money was taken away from the CDC that it had been spending on firearm injury prevention. Overall, gun violence research has received less than 2% of what would be predicted based on the burden of disease. In this graph, the gray shows like a regression line that shows that for most diseases, the amount of funding that has been allocated is essentially proportional to the mortality burden from an injury or disease entity, and gun violence just falls off the curve. And this is part of the reason why we haven't had this public health approach over the past 23 years. Luckily, that is changing thanks to the activism and advocacy of a number of groups. We did, for the first time in 23 years, get a $25 million appropriation from Congress to NIH and CDC this past December. That will lead to really important and transformative studies, but it is not enough. The estimated need is in the billions, not the millions. So what are we doing? So with that as background, kind of an overview of the current state of research, the current state of knowledge, and the current state of what we know needs to be done, what can we do going forwards? Where should research be going? What actions can we take? Obviously, I come from the perspective of Affirm Research, and again, apologies, this picture didn't come out quite right, but the American Foundation for Firearm Injury Reduction in Medicine, we're a nonpartisan nonprofit that has brought together more than 24 medical, public health, and nursing organizations, as well as firearm owner groups, to change the conversation around firearm injury to one of prevention, to create communities that are committed to implementing evidence-based prevention, and to educating and studying the effect of those interventions. As a group with Affirm and also as a larger kind of public health community, we of course led This Is Our Lane a year and a half ago now, fall of 2018, which helped to identify firearm safety as healthcare's highway, and which I believe was a large part of the driver for that funding for public health research. And it highlights that one important area of public health research is not just doing the research, but also speaking up about its value. We've talked about the value of this approach on national news networks, but more importantly, have been doing the research and education with groups of healthcare providers like AHA. This is a picture from a Trans Chicago Symposium that we did in October of 2019. That's Congressman Bobby Rush in the middle, where we brought together the various trauma and emergency medicine programs in Chicago to discuss the state of the evidence and to talk about kind of next steps for research within the Chicago community, research and collaboration. So again, when we talk about public health research, it's also essential to apply it. Northwell Health in the New York area in Long Island has also created a gun violence prevention program where they are similarly both educating and doing research at the same time to evaluate efficacy and to improve both education and interventions. As I already mentioned, there are a number of research agendas for us to build off of, which I would encourage you to read. This paper in particular provides a nice overview of what is currently known about the root causes of firearm injury and death and where we need to go next. And then we're taking the research that we know and putting it into practice. So this is a picture from the LOVE program, which is the hospital-based violence intervention program in St. Louis, which is one of the cities in the United States with the highest rates of gun violence death. I won't go into detail about their program because I know you are having other presentations on hospital-based violence intervention programs. But a really critical part of this program is that for the first time, thanks to the combined efforts of AFFIRM and the Emergency Medicine Foundation, we are able to research the efficacy of this program. So we're using Trans St. Louis data on firearm injuries presenting to hospitals across St. Louis and examining rates of recidivism or re-injury among those who present for a first time with injury before the LOVE program was implemented. And then again, we'll be looking afterwards. We'll be developing a predictive model so that we can assign the limited violence intervention resources where they are most needed and most likely to be effective. So a great way of how we're combining practice with research, doing natural experiments and using existing data. Another great example is that led by Emmy Betts, who is an emergency physician at University of Colorado. She developed the Lock to Live program with NIH funding, which is a beautiful thing that, again, identifies a clear public health need, which is that we know that 90% of suicide attempts with a gun kill the person versus only 10% of suicide attempts with another method result in death. So if we can reduce access to a firearm in a moment of suicidal crisis, we can decrease the risk of death, save that person's life, and help them get through whatever that momentary impulsive crisis is. We know that actually 90% of people who survive a first suicide attempt do go on to die of natural causes. So if we can reduce access to lethal means in the moment, we can have a huge downstream effect on those suicide rates. I highlight this study because from that public health research approach, Dr. Betts identified the rising rate of firearm suicide, identified that risk factor of access to a firearm, identified that although we know that lethal means counseling works, it was not happening in the emergency department because of lack of workforce, lack of comfort, and so developed this web-based program to counsel suicidal patients with access to a firearm on how to reduce their access to lethal means, including but not limited to firearms, and has just completed a preliminary study, which will be published soon, looking at the efficacy of this program. So it's a tremendously promising way in which we can do research to help all of us on the front lines in healthcare. Another example, also led by Dr. Betts, is the Colorado Firearm Safety Coalition's gun storage map, which has since been reproduced in a number of states across the United States, which identifies places where families or individuals can safely store their firearm outside of the home in a moment of crisis. Another example comes from my own group here at Brown. We are looking at ways in which we can use technology to reduce the violence that serves as a precursor to firearm injury among youth and to reduce the downstream consequences of exposure to firearm injury and death, the mental health consequences. And I'll be clear here, mental illness is not a risk factor for firearm injury. Certainly, suicide is deeply tied to mental illness, but it's also tied to impulsivity, et cetera. And mental illness does not serve as a driver for homicide or mass shootings. In fact, people who are seriously mentally ill are more likely to be victims of violence themselves than to commit it. So with that aside, my program of research really looks at how do we change those precursors to violence and then change the longitudinal after effects by using text messaging, social media programs, wearables, et cetera. And there are others doing this type of research across the country as well. I think it has tremendous promise for our ability to identify folks who are high risk for future involvement in firearm injury, and then to help change their trajectory by providing conflict management skills, by reducing post-traumatic stress after exposure to firearm injury, and by reducing depression and anxiety around the prevalence of violence. Preliminary results from a couple of these studies are really promising, showing significant decreases in the number of physical fights that kids get in after an automated text messaging program, again, with the goal of reducing the burden on our healthcare workforce, who are already overstretched and rarely have either time or expertise to provide these types of preventive interventions to at-risk youth. And of course, as I talk about research, I want to highlight the importance of research on the impact of gun violence for Black Americans, particularly Black women who are, I talked about the disproportionate effect of gun violence on young minority men, but Black women are most likely to be victims of intimate partner homicide by a firearm. And this is an area that has been largely ignored by the research over the past 23 years for a wide variety of reasons, ranging from structural factors to, of course, funding. At Affirm, we have the Tamara O'Neill Memorial Fund, which is committed to raising the voices and mentoring young Black academics in doing violence research, as well as funding research on this issue. There are some other folks across the country that are doing some important and groundbreaking work in this area as well. But because, as I've mentioned, the amount of funding was so low for so long, many of us either have done either just small studies, unfunded studies, or are just getting started with those larger studies that have been made possible by philanthropy, things like the Arnold Foundation and the Joyce Foundation, as well as Affirm, or by some of this new federal money that's coming forward. So in closure, as I promised, I would be relatively short with this talk so that we have time for Q&A. I think my takeaway for all of you, not knowing all of your backgrounds on this call, but the fact that you're on an American Hospital Association webinar implies to me that you are mostly involved in healthcare in some way, shape, or form and may have a leadership role in your hospital system. So the first thing is to learn the facts about gun violence. Again, I know that mass shootings are the thing that all of us just are so deeply worried about, but to understand, again, that this is something that affects Americans every day across the United States. There are different prevalence rates for different populations and likely different preventive strategies that need to be taken for those who are at risk of firearm suicide versus homicide. But we can't begin to create evidence-based interventions until we know those facts. Second, to share your stories. I started this talk with my own personal stories about why this issue matters to me. And as much as I am the world's biggest advocate for public health research and for an evidence base, I also know that what motivates us are those personal experiences. And so obviously in a HIPAA-compliant way, I would encourage all of you who do have experiences, either as clinicians or personally, to use those stories to contextualize why this evidence-based approach is important. Certainly, if any of you want to share those stories in a more anonymous way, feel free to reach out to me. One of the things that we're doing within Affirm is a new program called The Reframe, where we're using narratives to talk about the potential for prevention and then incorporating evidence-based education. And I'd be happy to talk to any of you about that. But storytelling is just such a critical part of change, and there is some evidence behind that. And then the third thing that I would ask all of you to do, and I know that the AHA, again, is having a series of webinars on this topic, but is to take action. And what type of action you will take will depend on who you are and what sort of hospital system or healthcare system you are part of. It may be about taking action to help better identify those at risk of firearm suicide and create interventions that are feasible and acceptable to the population in your community. It may be about creating violence intervention programs or thinking about how to identify those who are at risk of firearm homicide. It may be about helping to gather data and provide that to your local epidemiologist or working with your state Department of Health to better identify patterns of firearm injury and death in your community. There are a lot of actions that need to be taken because we did have that paucity of research for so long. And I just can't emphasize enough how important this third step is in whatever way, shape, or form you are capable. With that, I will close. One of my favorite quotes is, "Alone we can do so little, but together we can do so much," by the inimitable Helen Keller. And so I do urge you all to do something, whatever it is that resonates to you. I look forward to having you join us in both doing the research and applying it. I'll stop there. Thank you.
Wow, that was a lot of information in a very short time. We have plenty of time for questions and answers. So please do use the chat feature and send a question in. I'll get things started. It's got me thinking about so much, and thank you, Dr. Ramey, for debunking some of the things that we hear so much in the media and on the news, and kind of ring true. So it's easy to believe. So if my understanding is correct, that just addressing suicide by gun, suicide attempts by gun would reduce gun deaths significantly in this country. But it's almost as if, what the research is showing is we really have this multi-pronged focus we need to take. First is suicide prevention, which I know is an issue in and of itself, but with the gun violence, access to guns as being a significant risk factor. So I'm interested in knowing more about that. But then you mentioned that behavioral health issues are not really risk factors in and of themselves for victims of gun violence that are not suicides. But I think the thing that we hear so much, and I don't know if there's any research on this, is about the perpetrators of gun violence. So not the victims, but the people who, fired the gun. Is there any studies on that in terms of, the correlation to behavioral health as a risk factor? Can you speak? Is there any research in that area?
Yeah, that's a great question. So again, to reiterate, for victims, victims are more likely overall to have mental health problems. People with serious mental illness are more likely to be victims of violence, and certainly exposure to firearm injury increases the risk of consequent post-traumatic stress disorder, anxiety, depression, and substance use disorder. I will say that about 30% of both victims and perpetrators of firearm homicide are found to be intoxicated with either alcohol or other substances at the time of the shooting. So I would certainly count substance use disorder as being a behavioral health problem, and I don't want to overlook that is a major risk factor. And in fact, going to the further part of your question, Gloria, in terms of risk factors for being a perpetrator. So much of that research has been done in the criminal justice literature rather than in the health literature. There is one study out of California which reported that a history of being arrested for DUIs, driving under the influence while intoxicated, is a risk factor for being a future perpetrator of firearm violence. Which I find fascinating. So substance use disorder is in and of itself not just that people are often intoxicated at the time that they shoot, but presuming that DUIs serve as a marker of a substance use disorder, that is also a risk factor for future firearm violence perpetration. Other studies by the Secret Service and by threat assessment teams suggest that, to the best of our knowledge, among mass shooters, the prevalence of serious mental illness is perhaps slightly higher than that of the population at large, but but depending on which study you look at, not significantly so. Of course, there are questions as to whether mental illness was undiagnosed, but the best knowledge on mass shooters is that it's not significantly different, and then ditto for homicide as well. There have not been found to be significant differences in rates of serious mental illness among those who perpetrate compared to the average population, which I think is important. Again, it's critical for us to talk about the anxiety, post-traumatic stress, depression, and substance use disorder, which become prevalent in communities that are affected by firearm injury and death, and become very common, of course, among survivors, and which can then lead to risk for being re-injured. Because once you have a behavioral health disorder, you will often develop greater impulsivity or have poor decision-making skills or poor conflict resolution skills because of that overlay of mental illness or substance use disorders, but that those are often consequences of a first exposure to firearm injury. And it's why identifying folks and doing good secondary and tertiary prevention is so critical. It's an area, though, of burgeoning research, and I'm sure we're going to see more data coming out in the near future.
That is fascinating, and yeah, I'm sure the AHA will want to follow up with you on that. One more question on, the public perception versus what the data might show, and I don't know whether or not there is any data on this, but the concept of licensed versus unlicensed firearms and the efficacy of background checks. I don't know if there's any data or research in that area.
Yeah. So the data is emerging. There is data that states that have permit to purchase or universal background or they're two separate things. Permit to purchase and universal background check laws. There is some evidence that they have lower rates of both firearm suicide and firearm homicide, but the data isn't great, and there's a number of reasons why that is so. But there is very strong evidence that states that put in place a new law restricting access to firearms for people who are under a domestic violence restraining order or who have been convicted of a domestic violence misdemeanor, and who states that additionally close the so-called boyfriend loophole, which is that current federal law forbids firearm possession by someone who's been convicted of domestic violence, but only for spouses or cohabitants. So if you are an ex-partner or not, if you're a boyfriend or you're not living with the victim, that law, the federal law, does not apply to you. So states that put those laws in place that close those loopholes in the domestic violence laws do see a decrease in domestic violence-related shooting deaths. So there is strong evidence there. For people that are interested in policy-related research, RAND Corporation actually has an absolutely wonderful overview of the current state of the data and the current state of the research on which policies have evidence behind them. And I'll give you the short answer, which is that there are, at this point, not many, because there are a lot of confounders as to which states have which policies that make it difficult to judge. The other part that I'll say is that even the best policies require implementation and require culture change among the members of a population. And as all of us know with texting and driving, a law alone does not stop people from texting and driving. You really have to change community norms about whether texting and driving is acceptable, in addition to having a law in place. And so that's a big area of research by a lot of us is, for example, safe storage with kids, which is particularly important in the adolescent years. There are a bunch of us that are looking into how do we encourage safer storage by parents, again, particularly in those adolescent years where, regardless of what the state law is, you still have to have families understand the importance and comfortable with deciding to lock up their gun and make sure that the key is not available to the kid. I'll go back to that story that I started my presentation with. The young man who shot and killed himself knew where the key to his dad's safe was. And so, if when you think about safe storage, it is slightly more complex than many of us think about at first blush.
Wow. Very interesting. I've got one question in from our audience, and it has to do with data on, you had mentioned it in your graphs on males, deaths, young male deaths. This person wanted to know what's the data on deaths that are gang-related?
It's a great question, and there's not terrific data. We have crime data, obviously. But as we know, only around, depending on the city, somewhere between 10 and 20% of, or between 10 and 30% of firearm homicides in urban environments are solved. And so it's tough to say with certainty what percent are gang-related. And of course, the composition and design of gangs has changed tremendously over the last 15 years or so. It used to be during those kind of mid-90s drug wars that there were very clear gangs. Now, in many of the cities that I do my work in, it's really more about crews or neighborhoods. And so whether you identify those as a gang or not is tough to say. So you had asked before, Gloria, and this is related about illegal firearms. There have been a couple of studies showing that most gang-related shootings are done with a firearm that belonged to a friend or family member. It is unknown what percent are illegal firearms, but there is some data suggesting that a high percent are not owned by the person who does the shooting, so therefore in many states illegal. And it highlights the importance of reducing firearm sales to straw purchasers and the importance of empowering the alcohol, tobacco, and firearms enforcers to reduce the flow of illegal guns. And we find that states with very permissive gun laws often serve as the source of guns in states with more restrictive gun laws. So there's a movement of guns from a state where it's easy to buy to a state where it's tough to buy. But the portion that is gang-related is something that is under investigation, and we may never really know the full answer, but the important thing, again, is to figure out those risk and protective factors and develop appropriate interventions like hot spotting or peer interrupters.
Very, very interesting. Another question has come in from the audience, and it's related particularly to those regional variations. So the questioner is asking, so the flat line that you show in your graph for accidental shootings, is it consistent across states? This person is speaking in particular about Tennessee and wondering, if any states with lower rates have laws and policies, like what's there, to look at the difference, the variation regionally in accidental shootings based on states with laws and policies in place and affecting those cultural norms.
That's a great question. So there was a study published in December in the Journal of Pediatrics, in Pediatrics, that I and a woman named two other researchers, Renad Batis and April Zioli, wrote an op-ed on that I'd encourage this questioner to look at. And again, I'm happy to provide links. And this study showed that states with more stringent safe storage laws have lower rates of childhood firearm injury and deaths. In terms of the number of accidental injuries in various states, yes, we see higher, or unintentional, we see higher numbers in general in states with, of course, higher firearm prevalence. So if there are more firearms around, you're going to have more kids that shoot themselves, which makes sense. You'll have more car crashes if there are more cars. But again, there is also this potential correlation with kind of the legal regime in a given state. But changing those cultural norms is critical, and there have been a couple of really nice studies done looking at safe storage counseling in pediatric practices that have shown some really promising results because the laws alone are not sufficient. And you'll see if you look at that pediatrics paper that there's a difference, but it's not a huge difference, and there's a lot of room for us to do better. So would recommend that the questioner looks at that paper.
Excellent. I think we have time for one, maybe two more questions. The next question from the audience is there anything that you could point to that compares trends or correlations between gun injuries and trends in gun deaths? Like, do they move together, I guess, or is, I don't know what the question is.
Yeah, that's a great question. So I'll say I didn't talk a lot about injury data in my presentation, and that's because the CDC's injury data is tremendously unreliable. The way that they gather and present it has been, a few of us kind of called it out a couple of years ago, and so I just don't feel comfortable with presenting the injury numbers. Those that were on the CDC website suggest that there is an increase in gun injuries that parallels the increase in gun deaths, but it's not trustworthy data at this point, and hopefully we'll have better data soon.
Great. I was wondering, as my last question here, now that we're sort of in week 15 of, a shutdown, and I have my own personal theory about lack of sports on TV. Is there any new data in that you can look at to see whether or not there have been any spikes in gun violence? I know I'm in upstate New York, and I know that Albany has seen a tremendous increase in gun violence these past few months. So I'm wondering if there's any preliminary data on that, and whether or not what's your thinking as to how what's going on now will lend to the research?
Yeah, that's a great question. So this has been an area of tremendous interest by many of us, and I know that there are a few researchers out there looking at those trends. The preliminary data suggests that there has certainly been no drop in firearm homicide, and may have been an increase in firearm homicide, particularly during the month of May. So numbers it looks like maybe numbers decreased in March and April as people were under stay-at-home orders, but in May, firearm injury and homicide in particular increased with a vengeance in many cities. Is the preliminary data, but many of us are looking at that. And I think, as I mentioned, 40% of gun buyers during COVID-19 were first-time gun buyers. Most of them did not get safety training, right? It's questionable whether they also bought gun safes or other safe storage mechanisms, and so there is a concern about what will happen down the road if they don't get adequate safety training and are not provided with safe storage facility access. Kind of encouraged to store their new firearms safely, because it's like you wouldn't just let somebody buy a car and go out and drive it without making sure they knew how and were safe. And many of us encourage the same for firearms, that we need to make sure that people know what the risk factors are and know that drinking and shooting is not a good idea, and know how to minimize the risk of injury or death for themselves and for their families.
Wow, I think I could keep asking questions for another hour, Dr. Ramey. I really appreciate how much work you've done and everything you continue to do in this very important research area. As I said at the beginning, and you said so well through your presentation, if you don't have the data, you don't know how to address the real problem. So I really appreciate your time, everybody. There is a link here to access the AHA's resources. If there are additional questions for Dr. Ramey after this, please send them our way, and we'll make sure that we get that conversation going. And I want to thank everybody very much for participating in today's webinar. And now I'll pass it back to Stephanie for a wrap-up.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.